Next, we'll be talking about the pharmacologic management of dementia. The main medications that we think about using are cholinesterase inhibitors and memantine. So in most forms of dementia, there's generally a loss of cholinergic neurons. In Alzheimer's disease, this generally tends to be in the hippocampus. And so cholinesterase inhibitors can help prevent the breakdown of acetylcholine. We know that the most common side effects with these medications often tend to be nausea, vomiting, diarrhea, so these GI side effects, which can lead to weight loss. The cholinesterase inhibitors also can lead to bradycardia. Memantine can lead to aggression, confusion, headaches, and dizziness, and tends to be more indicated for more advanced or at least moderate dementia. When we look at use of these medications and whether they can improve behavioral disturbances in dementia, when we look across pooled meta-analyses, there is a pooled benefit for use of cholinesterase inhibitors. And in general, they reduce the neuropsychiatric inventory by about 2 points. However, this is a scale that ranges from 0 to 144. And so this is a statistically significant benefit, but jury is still out whether or not this is a clinically significant benefit. I think we can all think about patients where we've used these medications and it has been helpful. Maybe a situation where I'm more inclined to use cholinesterase inhibitors would be in the setting of Lewy body or Parkinson's disease dementia, where patients may have troublesome visual hallucinations. There can be some evidence that cholinesterase inhibitors can be helpful in treating those visual hallucinations. Use of cholinesterase inhibitors are indicated in all dementia severities, and generally we will start with donepezil or Aricept first and then switch agents if side effects develop. For patients who have significant GI side effects with use of oral medications, there is a rivastigmine transdermal patch that generally can help bypass some of those GI side effects. Memantine is generally titrated over 4 weeks to 10 milligrams twice daily or a 28 milligram extended release version and is indicated for moderate to severe dementia. And we will often think about reducing the dose if patients have persistent confusion or chronic renal impairment. And the decision when to stop treatment can be difficult. In general, we recommend stopping treatment in severe or end-stage disease where there's an inability to respond to environment, dependence on others for most activities of daily living, or there's limited life expectancy, such as when folks are entering hospice care. But there really needs to be an update to guidelines both to start as well as to discontinue these treatments. Newer agents that are out are amyloid-targeting treatments for individuals living with early symptomatic Alzheimer's disease with confirmed amyloid pathology. And the 2 medications that are out are lecanemab and donanemab, which are Leqembi or Kinsula. And these medications bind to amyloid and remove amyloid buildup. And they're given as an infusion every 2 weeks, and dosing is based on weight. And PET scans have shown that these medications can lead to removal of brain amyloid. And in research trials with lecanemab and donanemab, they found that persons with mild symptoms of Alzheimer's disease experience less decline in thinking and daily function at 18 months on the medication. And so there was moderate slowing of cognitive decline. However, these medications do come with significant side effects. They can have infusion-related reactions, and something we worry about is called ARIA, or amyloid-related imaging abnormalities, which are swelling and brain bleeds, which require monitoring with recurrent MRIs to check for this. And they are not recommended for patients who are taking anticoagulants or thrombolytics. These clinical trials also excluded patients with stroke or TIAs, patients with bleeding disorders, seizures, or severe depression. So we don't know how these medications or the safety in those conditions. Treatment is generally for 18 months at least, and I think there's still questions out about what ongoing maintenance might look like after that. and recurrent MRIs are needed for monitoring to look for these potential brain bleeds or swelling. The cost is about $27,000 to $32,000 per year, covered by Medicare. MRIs are generally indicated within 1 year prior to the start of treatment, and then follow up prior to the 5th, 7th, and 14th treatment, and continued MRIs for selected patients. I'll mention Nuedexta, or dextromethorphan quinidine, which is a combination approved for pseudobulbar affect, which is used off-label for agitation and Alzheimer's disease. This has been investigated for off-label use through a study called Triad, which demonstrated statistically significant improvements in agitation symptoms for patients living with dementia. However, there are some significant safety concerns, including QT prolongation, dizziness, and falls. And you want to use in caution with frail elderly and requires monitoring EKGs. So key points for this section: cholinesterase inhibitors are indicated for mild to moderate dementia, and the main side effects include nausea, vomiting, and diarrhea. If those GI side effects become too troublesome with oral medications, there is a transdermal patch, the rivastigmine patch, which can be used. Memantine is indicated for moderate to severe dementia, and the main side effects include confusion, headaches, dizziness, and aggression. Anti-amyloid infusions for early Alzheimer's disease with confirmed amyloid pathology. They can slow cognitive decline slightly, but there are significant side effects, including ARIA, which are brain bleeds, and swelling. And these medications require serial MRIs for monitoring. Nuedexta, or dextromethorphan quinidine, may reduce agitation in patients with Alzheimer's disease, but requires caution due to QT prolongation and fall risk.